Welcome to the EAU podcast. In this episode, new recommendations for prostate biopsy, from indication to optimal strategy and treatment planning implications. Today we are joined by Professor Francesco Sanguedolce, Professor Francesco Giganti, Professor Gianluca Giannarini, and Professor Lars Budäus. Together, they will provide a practical discussion of the new pro-biopsy consensus on prostate biopsy, with focus on how recent evidence and expert consensus may influence biopsy indications, biopsy technique, and treatment planning in contemporary prostate cancer care. Join us as we embark on this informative journey.
Good evening, everyone. I am Francesco Sanguedolce. I'm a urologist from Barcelona and also the chair of the imaging section of the EAU. And this afternoon, we got the pleasure to discuss with three worldwide experts in prostate biopsy, as we are going to talk about indications, how to undertake, and which will be the information that might be useful for the treatment in relationship to the prostate biopsy for prostate cancer. So we have three exceptional colleagues. One is a radiologist, is Professor Giganti from University College London, and then will be the turn of Gianluca Giannarini, a urologist from University of Udine in Italy. And then Lars Budäus, Professor Budäus from the Martini Clinic in Hamburg. So we are going to cover three different topics dealing with a paper that has just been accepted in European Urology and is currently on process for the press. There's been a consensus Delphi process that has been run in the last months, trying to cover different topics that might have some gap in the evidence in literature, as well as in blurry recommendations or no recommendation at all in the European guidelines. So I would like to first invite Professor Giganti to address some questions. Francesco, it's very nice to have you this afternoon. Thank you for joining us.
Thank you, Francesco, and thank you for the invitation.
So we had a very nice time doing the consensus. They were obviously, so we did, and the way you actually undertook a couple of similar consensus. One was the precise version 2 and the PyQual as well. And so we had a very nice 2 rounds of discussions, but there were also some topics that were a little bit debated. So in terms of especially the imaging wise, you have been the one prompting and highlighting the need of a high quality of MRI. Why quality is key in MRI, and how what should we do as a community of experts and in generally speaking in the world to homogenize this standard across the countries, areas, and also between different centers of the same areas.
Yes, thank you, Francesco. So yeah, as you pointed out, image quality, I think, is the most important thing in prostate MRI. Comes also before assessing the scan itself and giving a PIRA score. Because if the quality is not good, then the whole study is flawed, right? And so we will have the risk of overcalling or undercalling things because of the quality is not adequate. And this is the reason why actually we keep on stressing these things in all these meetings and the consensus statements, because quality is key. What we did, for example, for the PRIME study that was published last year, as you all know, basically is the study comparing biparametric and multiparametric prostate MRI, basically was to evaluate the quality beforehand. And what we saw was that the quality was not optimal before starting the study. And basically we gave a feedback to the centers wishing to take part into the study to improve the quality. And this, I think, is one of the best things that we can do if we want to improve the quality worldwide. So I think one of the most important things is to stress, both in the radiological, but also in the urological community, the importance of image quality. And in terms of radiology, we have some guidelines, the so-called PIRAS guidelines, that basically tell you how to acquire good quality MRI, which kind of parameters you have to stick to for each different sequence. And as you also said, we have a dedicated scoring system called PyQual version 2, and it was good to see that actually this was also an effort along with the EAU because again, urology and radiology are very have to work closely in this field, and the PyQual version 2 is a streamlined way of assessing the quality of the scan, and this is the reason why the radiologist should always look at the quality, giving the urologist an assessment of the quality, and the urologist, on the other hand, should also be able to understand what PyQual is and what image quality is, because this has a huge impact in the biopsy treatment planning and so on.
Thank you very much for your answer. The question is, so obviously there can be some efforts, because we said that one of the key findings of our consensus was that biparametric and multiparametric MRI could be equally informative for indicating a prostate biopsy, provided that there's a high quality, obviously, assessed according to the imaging acquisition. So do you think there might be also some or should be a proactive involvement of the urologist to see or to identify those image qualities that are suboptimal, that may require eventual repetition of the imaging acquisition?
Okay, so I think that the evaluation of the quality itself is something that basically stays in the radiological world, and this is one of the most important tasks for the radiologist, but also for the radiographers, for those acquiring the images, is to know how to do a good quality MRI. What I think is good for the urologist is to know that quality must be evaluated, and every single urologist, in my opinion, should ask their local radiologist to check the quality. And when we do our tumor boards, MDTs, we should always ask, is the quality good? What do you think of the quality of the scanner? So don't be afraid of asking this. And I think this is the most important thing. On the other hand, another really important thing is not the quality, but also the expertise of the radiologist. So if we say that biparametric is non-inferior to multiparametric, as we stressed in the PRIME study, we also have to stress the importance of having dedicated and skilled radiologists looking at good quality MRI. And this is how prostate MRI should be done and reported.
Yeah, I agree fully. We also asked the experts, overall there were more than 40 experts from all over the world that address these issues from different specialties. And one of the statements, or what we call also stems, that we were being challenged with the experts' opinions, was about the role nowadays of PSMA and micro ultrasound as the emerging imaging tool available now, also for diagnostic. Well, for PSMA, we know obviously for staging is nowadays the new frontier. But we ask also what might be the role of PSMA in diagnosis phase, as well as to the micro ultrasound. And we found there were somehow a disagreement, in generally speaking, to consider these tools as replacement of MRI. And the only consensus agreement that we reached was about the PSMA as a complementary test. When, for example, there might be some indeterminate or negative MRI expression with high suspicion of prostate cancer. How do you explain this? Why we don't yet are there? Also, these involve the micro ultrasound, and after the publication of the Optimum trial last year.
Yeah, so I think, first of all, I always say that prostate MRI is a love story of 40 years. So the first time in prostate MRI was from 1982. So we have experience. We have 40 years of experience in doing prostate MRI. While for PSMA PET and micro ultrasound, now the experience, of course, is less. I'm not saying they're not important at all. What I'm just saying is that we have gathered so much evidence from prostate MRI, and we are not there yet. For example, with micro ultrasound, we have only one trial that you mentioned for this. PSMA PET, as we said, basically is very important as a complementary tool. One of the reasons is accessibility. So it is not widespread as prostate MRI. And of course, also there is an exposure to radiations. So basically, it's really important that we ponder how we want to use these tools. So prostate MRI is here to stay. That's my view. And it's a good diagnostic tool. But of course, we also need to use other tools, like, for example, PSMA PET, when we know that we are not good at it because of, for example, the quality. For some patients that have basically maybe they can have a good quality MRI, or for patients with a very high PSA density, we need to explore also other things. So I see all these things as complementary, with MRI at the moment as the most important diagnostic tool in terms of imaging, of course. That's my view.
It makes very much sense. Very quick question or hopefully a quick answer. So where we are standing now with artificial intelligence, this was a topic that we addressed marginally in the consensus because there was not enough evidence in support of it. What's your opinion on this regard?
Yeah, so again, my personal opinion is that AI is here to stay, and we have to collaborate with AI. I think we should not be against AI, but we have to make AI work. And this is my point of view, basically. For MRI, for example, we have plenty of AI tools that can produce interesting results, but we don't have, at the moment, enough data to support its use, clinical use. Like, for example, there is a lack of multicenter studies or randomized studies, internationals, that can prove that AI is good in different settings. So it's a very important and evolving field, and I fully support the exploration of this field in MRI.
Yeah, in fact, that'll be also what was the opinion where we found a consensus agreement that artificial intelligence algorithms could be helpful as soon as is used upfront before radiologist assessment. So eventually to somehow support the radiology report. Okay, thank you very much, Francesco. Very much interesting stuff there. And I'm just moving now to next bunch of questions to Gianluca, Professor Giannarini. Thank you, Gianluca, also to you for your time here this afternoon.
Thank you very much for the invitation.
Pleasure as well. And so, very first firing question. What is your opinion in the sense added value perilesional biopsy? Just remember, when it was called Twitter X, you sent some very interesting comments on a paper demonstrating the utility of the penumbra sampling. What is penumbra? What is a perilesional biopsy? Why is adding any value to our biopsy, targeted biopsy?
You're right. I'm personally a supporter of this approach. And so at the beginning, I think right after the document published on European Urology, we started finding some nice names. And the first was a focal saturation. And probably it was linked to the treatment. So having a good sample of the tumor just to be sure that your focal therapy would have been good. I think the consensus is now to call perilesional, and I think we have multiple arguments to support this approach that is gaining interest and evidence increasingly. So number one, for me, the most compelling one is that it can compensate for the targeting errors or inaccuracies. It is also less dependent on size, location within the prostate, maybe less dependent on the expertise of the operator, and it can more accurately estimate the extent of the tumor, because we know, especially for larger lesion, MRI has this limitation that it underestimates the real volume of the lesion. So that could be nice and a good way for your planning, for example, again, for focal therapy, or, for example, intensification with radiation, with boost or nerve-sparing surgery. Another advantage is that reduces the number of systematic biopsies that probably are not so good in terms of potentially increase the detection of clinically insignificant prostate cancer as well in the gland, and probably reduce the complication, or the cost for sure, the discomfort for sure of the patient. Also, you were mentioning the penumbra. So we have beautiful papers, and for example, the Brisbane et al. Is one of the most convincing ones. So the penumbra means the area around the lesion. And we also had the consensus as at the biopsy project that the penumbra should cover 1 centimeter radially around the region of interest if we approximate this to a sphere, for example. So I think we have many reasons to support this new way to target the lesion that we have discovered in the MRI.
Thank you very much, Gianluca, for clarifying this. Yes, it's exactly what we done with the exercise of the consensus to basically provide some standards that are not described somewhere else. There being also this area called ipsilateral biopsy, regional biopsy. So we know. So we hope in that with the consensus we can prompt a sort of standardization in the nomenclature, let's say, when I'm referring to these extra calls taken around the region of interest. And one of the issues were also how many biopsy we should take around this area, where these should vary according to the lesion size, the Pilat score. And then we got actually some mixed opinions where some cases we found some agreements, in other cases no. So what's your opinion on that?
This is one of the most controversial issues so far, because apparently all the experts agreed on the fact that target and perilesional biopsy is the way to go in most cases of biopsy-naive individuals. But then, I mean, this is also a nice thing of this consensus. We didn't reach consensus on the number of in-target and off-target cores. We had some popular responses, but oddly, we didn't get a real recommendation in the end. So in my view, for sure, prostate biopsy has changed a lot over the years, and to become a really individualized procedure. So we can really talk of a precision biopsy. And if it should be individualized and personalized, of course, we should. The major determinants are, of course, the Pilat score, but we can discuss, and the size of the lesion, of course, within, for example, a Pilat 4 lesion, and probably the volume of the prostate. So it is not the same thing to perform a biopsy in a 20-gram prostate, for example, with a high PSA density, or in a 90 prostate with a Pilat 4 of 7 millimeters. So there should be some stratifiers, of course. But as we've seen, it was not easy to come to the conclusion. So for sure, a certain amount of target should be covered. Of course, should be covered. The target probably minimum is 2, maybe up to 4. You have some data. And extra target is more difficult because, of course, if one believes that you have to cover all the penumbra, for example, for a 2 centimeter Pilat 5 lesion, then you have to increase the amount of perilesional biopsy and distribute them evenly up to, 7, 8. So that probably is too much, but I think one of the messages is probably that we have to run trials. And as we've seen for the tissue transrectal transperineal, then we got these RCTs in the end. It should be quite easy, but maybe 40 years is best. So we should work together not to lose time and come to some evidence in another 40 years.
Oh, thank you very much. So, an area where there were some different opinions. What we surely found was a consensus, at least for the largest lesions, where, as the lesions, when the lesions are a bigger size, 1 centimeter or more, probably it's less necessary to intensify the sampling of these perilesional penumbra area. And what is actually more controversial is how many calls you have to take for smaller lesion, because it's where actually you may have a higher chances to make an error or missampling. So the last question for you is there any role nowadays for cystatic biopsy? Is it still justified?
I think we should never abandon systematic biopsy, of course, we should reduce, and we learn how to reduce the indication for a systematic biopsy. But for me, for example, a still frequent scenario in 2026 is the negative MRI, with, of course, persistent clinical suspicion, be it PSA density high or rapidly rising PSA, abnormal DRI findings, or family history, strong family history, for example. And so I think if you perform this biopsy, because of course there is no uniform practice around the globe, but if you perform, then you can find cancer. So of course, based on the risk factors, this is also begs other questions. For example, what is the role of discussion of these cases within the MDTs? Sometimes we had to repeat the MRI, sometimes we had to reconsider the indication for biopsy, but this is another story. Another, of course, indication to me is quite frequent. So patients, I would say patients where you have the risk, the diagnosis of an advanced prostate cancer, of course, or metastatic prostate cancer, so you can skip even the MRI, or when you have quite common in the practice when you have a suboptimal MRI quality. So Francesco stressed the importance of the quality. Sometimes it is difficult to call a second read of the MRI if it is possible to save that low quality. Sometimes it is not practical to redo the MRI. Sometimes the patient, they want just the answer with a biopsy. So in these cases, probably I will go for a systematic biopsy.
It's a very important aspect because this is the reason for why in many other settings, in meetings, congresses, many people that are in support of the systematic biopsy are still wanting to have at least the contralateral sampling, if not the whole systematic sampling, can exactly to obviate to the issues for eventual suboptimal MRI, which is for me basically is like to solve a problem with an old problem. So basically, obviously, probably we need to make some step forward, either way in which Francesco was mentioning before, in order to definitely make sure that quality of MRI is there, and basically increasing in a homogeneous way its availability. Thank you very much, Gianluca. Very much interesting discussion. Introduced me again, Professor Budäus. Lars, thank you very much this afternoon for joining us.
Yes, thank you for the invitation.
So, Lars, please. So we have during the consensus, a third domain dedicated to different statements regarding how the information that we can gather from different schemes of biopsy may affect our surgical planning, being this focal therapy, our nerve-sparing surgery, the indication for lymphadenectomy, and so forth. But one of the main issues was, for example, whether the current recommendation of the targeted biopsy plus perilesional sampling will be enough informative to indicate focal therapy. And the consensus was not reached for this scheme, but rather that still information are needed from the contralateral biopsy. So what's your opinion on that? So why in the era of the MRI driven pathway, we still need a systematic biopsy, or at least information from the contralateral biopsy to indicate and plan our focal therapy?
Yeah, I think it's an important issue since the targeted biopsy and the perilesional sampling is adequate for lesion characterizations. However, focus therapy requires confidence that the untreated lobe does not harbor relevant occult disease, and therefore we need to get everything out of the diagnostic pathway which is possible. And therefore the consensus explicitly supports the targeted and the perilesional biopsy on the one hand side, and also the contralateral systematic biopsy to reduce the undertreatment of MRI invisible lesions in this opposite lobe.
Yes, this was exactly the main comments from the a majority of the panels, but there was still a subgroup of other experts that were actually supporting the idea that this is not necessary. So still the controversy there, and maybe we need some time in the future to see whether things may change in one way or another. The other thing that we thoroughly discussed was whether the same information could be applied also to planning our surgery. We know that, for example, your center is very famous for the ability to identify intraoperatively the eventual positive margin to eventually adjust the resection on or to the bundles, but everything including also the indication to the lymphadenectomy. So it's still in most of the centers based on the information provided by the nomograms, which have been developed on the basis of the results of also the systematic biopsy. So by lacking this information, how do you think this might affect the indication of one or another approach during radical prostatectomy?
So basically, in our institution, what we do is this neurosafe approach where we slice some parts of the prostate and send it to the pathologist, and they provide us with the information on the margin. And for sure, they also provide us with further information on the Gleason score so we can opt for or against lymph node dissection. However, for nerve sparing, in the consensus, the panel considered that targeted biopsy and perilesional biopsies are sufficient in unifocal disease and sufficient in bilateral MRI visible disease. However, for lymph node dissection, no consensus was reached in unifocal MRI visible disease. Probably because many nomograms were built using systematic biopsies. And this is a flaw once we introduce current biopsy results into older nomograms, because we overestimate the risk of tumors.
That's a very good answer because, yes, definitely there might be a recalibration of the nomograms based on the information on the targeted base biopsy scheme. So you're perfectly right, and this needs to be addressed by further studies that are already ongoing at the moment. Definitely, this is overall an important finding also in our consensus because highlight that basically there is no a single biopsy scheme that might fit for all the indications that we need for planning our treatments. And so basically this might be a sort of limitation and may prompt maybe some scientists or urologists to diverge from the recommendation for the guidelines. So, and the last question to Francesco and Gianluca. So, how do you explain lack of confidence or still substantial proportion of urologists undertaking a surgery based on target plasma or perilesional biopsy only? Would you think that this may increase the number or the rate of rebiopsy after targeted biopsy? So how we can tackle this issue? Because it looks like there's somehow asymmetry between what actually in the guidelines is recommended and what actually in the clinical practice urologists are confident to do.
I think the lack of confidence here is, first of all, again, image quality. So if the urologist doesn't know that the quality is good, the lack of communication also between the urologist and the radiologist. And I think this is crucial because this is what we have always been advocating. As you know, when we run our prostate MR courses at the EAU and the different workshops that we do, so between the two societies, I think this is key. So to me, actually, in order to reduce this issue, we should create teams in every single hospital or a center doing prostate biopsy, focal therapy, or radical prostatectomy at a certain level. There should always be a dedicated radiologist and urologist who sit together before the procedures and look at the images and discuss the different things. It's not only that the urologist has to understand the images, but also the radiologist needs to learn what kind of procedures the urologists do. And this is the only way for me to tackle the issues of losing confidence in the technique and also in the reporting radiologist. So I think it's a matter of communication between the two different specialties, which I will never stop saying this is crucial. And this is what we keep on doing this with the EAU, the SUR, and different the different societies. That's my view.
Interesting, very much. This from the radiological, point of view. And Gianluca, how would you conclude or add to these statements from Francesco?
Yeah. I think I have my opinion on the nerve sparing surgery, and I always believe that if we have to go for a nerve sparing that can be beneficial for the patient, then we will go for a fully bilateral nerve sparing. And these patients, we have to be honest, are fewer and fewer nowadays. I think everywhere across the globe, because of course the profile of the disease risk on the OR table is increased towards intermediate to high risk. Because fortunately, many of these patients we manage with active surveillance. So and so just probably because of this, if I have to go for a bilateral nerve sparing in a young patient, then probably just because these patients are few, I will probably explore the whole prostate, but believing that probably if the quality is good and if the communication with our radiologists, as we have the fortune to have in Udine, is good, then probably target and perilesional is the way to go, even for a fully bilateral nerve sparing in a young patient.
Okay, so I think we covered most of the key findings of these consensus, which has been called pro-biopsy. And thank you very much all the three colleagues, and that are also member of our fantastic section that I invite everyone to join. Surely at the time these podcasts will be issued, and we'll find these already available online. Obviously, we encourage you to read it, and then it will be there to eventually address any further questions and see, obviously, how these findings will have a penetration in the clinical practice. Thank you again to all of you, Francesco, Gianluca, and Lars, and have a nice evening to everyone. Thank you.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.